the Device and Arrhythmia Society in Tanzania. And this is an official society which is working towards improving cardiac care in the country, and which has an aim to improve rhythm disorders and protect patients who are having sudden cardiac death. Now, today's topic, like Dr. Moiz mentioned, it's also very dear to me because acute myocardial infarction, what we are going to talk about, is one of the things where time is of essence in treating acute myocardial infarction. And it's something which I think we all need to advocate. Would like to, on behalf of I'm the vice chairman of the Dar Arrhythmia Society, and on behalf of my chairman and executive committee, we would like to welcome all the participants and my colleague, Dr. Michael. He's our subordinator in the society who oversees all the HR solutions in the society as well. We also, as we go on, this is a roundtable discussion, so we'll be discussing the cases, and we don't want to be monotonous on presentation only, so we'll be discussing in between about how STEMI patients present and what are the important steps one can take to save the dying muscle in that limited time we have. We also thank MCure, our partners, who have supported this CME activity, and Battery Health Professionals. So with all, we welcome you this evening for the enlightening presentation. And this is not the first of all, this is first of many. And I think this roundtable discussion is our beginning to start with STEMI, but we'll bring you more cases in different parts of cardiology, not only cardiology, but also in emergency medicine, as Dr. Moiz introduced everything, right? So with that, I think good evening once again to all of you, and I think we can start.
Okay. So thank you, Dr. Khuzeima, and for the enlighten up about the Device and Arrhythmia Society. And thank you for appreciating that this roundtable discussion is going to be in both perspectives, both cardiology and emergency medicine. As far as by 90%, I can say, Dr. Moiz will correct me, the emergency physician here, probably all emergencies that are going into the to the emergency department, they are more likely related into the cardiac issues. So there's no way that we're going to separate the two specialties apart. Yeah. So as far as time is not our good ally, so I think we can start. And this particular CME is named as decoding STEMI. So we're going to decode and give out, to scan and give out some codes for STEMI. So the first presentation will be taken by Dr. Moiz, and then this will be, and the title will be Presentation on Acute Coronary Syndrome. So welcome, Dr. Moiz.
Okay, first of all, just checking technically, because you know how good we are as Tanzanians when it comes to technical things. Can you see my screen? Yes or no? A quick yes or no, we start early.
Yes.
All right, we see it. Thank you. Okay. So, let me start with an emotional story. And with that, we need some music, I think. So, my grandfather, he passed away of the same condition. It was late at night. He went to my grandmother. And I don't know why, but he started saying, sorry, you know, I have hurt you and things have been rough and I'm having a chest pain. That was the last part he said. And my grandmother was like, you know, you're being very emotional. So please, let's go to sleep. And tomorrow morning, just like any other Indian family, we'll go to the hospital. Next day, he was fit and fine. He wore his shoes. He's now going to work. And then my uncle gets a call after 2 hours of him being at work that your father has collapsed. Come quickly. So we went to the hospital. And on the way, he lost consciousness. He lost his pulse and he was not breathing. Until that time, I thought, you know what? I will be a doctor who catches STEMI. Either a cardiologist, either emergency physician, but I will catch a STEMI whenever I can. And that is why this presentation is so near and dear to me. So let's start off, and we are going to talk about acute coronary syndrome. I'm going to talk more about STEMI, and we are going to make it like a discussion, because we have a panelist on board. So this is from Dr. Khuzeima's slides, and it talks about cardiovascular diseases. It's the most common cause of mortality and morbidity worldwide. Okay, 3 million people are affected by myocardial infarction worldwide. out of which 1 million are from USA. It's no surprise, because if you look at it, I was in the ship and I saw each and every person, the third person who entered the ship was obese, hypertensive, and diabetic. So that shows that how serious this disease is in the US. If you come to sub-Saharan Africa, we are seeing the incidence also rising. It's rising because hypertension and diabetes and obesity, which are risk factors, are also rising. Now, in Tanzania, it has been shown that ACS is the fourth leading cause of death. However, if you go to the peripheries and you ask the doctors, okay, hey, do you know what are the start medications you give if a person is having a STEMI? They won't know. They start saying heparin, enoxaparin, fluids, and you get surprised that why are these doctors not trained? So that's one of the problems which is there. Doctors are not able to recognize with simple ECG that this is a STEMI. The second issue is people. They're not aware that if it's a chest pain, I can do ECG even 5 times on it. Not just one ECG, and then they start thinking, oh, you doctors, you are taking money from us, you know. But I usually, what I do an ECG, okay? Don't tell my hospital this, but I can repeat ECG 5 times because that cost of paper is not that much, but the life is worth more, okay? So I'm just going to talk about JKCI in 2023, and maybe Dr. Khuzeima will shed some light on this. The total number of cases that we did were done was 69, out of which 54% were direct, meaning these guys knew that JKCI is there, we should send the patient for cath lab. Those 46, they were thrombolized first and transferred. And ironically, Northern Zone and Zanzibar were more commonly referring such patients. And door to balloon time was under 90 minutes. The unfortunate thing is that we took more than 12 hours. And we said time is muscle. So more than 12 hours, meaning your muscles are dead, right? So this is something that I wanted to talk about because it's important. And this is just the basics of ECG. I know there are many cardiologists in-house here, and they might think, oh, why is this emergency physician teaching me ECG? So I'm just putting it out there for all junior doctors as well. So STEMI criteria, and I really want you to tell us about this. AHA says that you should have an ST segment elevation, okay, like this. Okay, you should have an ST segment elevation like this, which should be more than 1 millimeter in all the other leads. But when it comes to lead V2 and V3, you should have ST segment elevation based on the sex. Women, it should be more than 1.5. And male, it should be depending on the age. So if it's more than 40 years old, 2.5. And if it's less than 40 years old, it's 2.5. And if it's more than 40 years old, it's 2 millimeters. It's understandable because after 40 years, we lose our muscles from all areas. So is this true? Should we focus on this?
So this is a very interesting slide. You know why they take a woman? Because you see, a woman chest mass is the breast. Now, when we are doing an ECG in women, the placement of the leads are sometimes very difficult because of the breast tissue. And sometimes the ECG, what is the ECG? Is an electrical current signal from the heart to the surface of the skin. And sometimes the muscle mass, like you are saying, might prevent the typical ST elevation in a woman because of the breast tissue, or the placement of your leads on the anterior chest of a woman. And that's why whenever you're putting your chest leads, the V1 and V2, make sure that they are exactly at the intercostal base, at the mid-clavicular line, mid-sternum, at second or third intercostal space. So make sure you palpate this space. And this is what I see. Some people are putting them here. Some people are putting them here. No one is palpating. And the second, the lead 3, 4, 5, and 6, if you see, you need to hold the breast tissue up and then try to place. And all of that should be between two leads. There should be at least 2 centimeter gap like this. So this is how I teach the measure. So 2 leads here, then from lead V2, put your 2 inch like this and put your lead 3. Then you put this one and then you need lead 4. 2 centimeter lead 5 and lead 6. Now we have seen sometimes the breast tissue is so much, I've seen people putting on the tummy. Because they think that this is obstruction, right? And that's why this criteria of reducing the amount of millimeters because of the transmission of electric current from the inner heart to the breast tissue might sometimes be. So that's why they say a little bit tricky about 1.5 and 2 millimeter men and female.
Okay, all right. Thank you so much for that. So another criteria is that you need to have two adjacent leads. Okay, now adjacent leads I'll be talking about in my next slide, that what are adjacent leads. Okay, and you need to have reciprocal change. That means a ST depression in the opposite leads. So I'm going to talk about that in my next slide, and then you guys can shed some light on it. Okay, so this is the ECG that you see. Okay, now when you look at lead 2, 3 and AVF, this is signifying inferior wall. It's looking at, like, as if you can take a photographer and he's looking at the inferior wall. That's inferior wall. Okay, lead 1, AVL, V5 and V6 is looking at the lateral wall. V1, V2, V3 and V4. V1, V2 is looking at the septal wall, and V3, V4 is looking at the anterior. And from this only, you can tell which artery is affected. I was really surprised. At times he used to go, and when I was a junior, I was surprised. This is a LAD. I was like, how did he know? That means this. He looked at this one, and this is very important for everyone to understand. So, lead 2, 3 AVF is adjacent leads. Okay, and I have a very good mnemonic to know which is the reciprocal. It's called PAILS. PAILS. So if you have an anterior wall MI, for example, then the reciprocal change will be in the inferior wall. If you have inferior wall MI, the reciprocal change will be in the lateral wall. And that's how you, that's one of the criteria. So first criteria is that you need to have two adjacent leads with the MI more than 1 millimeter in any of the leads. And then you need to have in V2, V3 according to the age and sex, right? The second criteria is that you have to have reciprocal changes, and this is how you do it. And now, what about anterior leads, Dr. Khuzeima? What if you get V2, V3, V4 isolated ST segment elevation? Should I say that this is not an MI?
So you see, sometimes we get isolated. When do we get an isolated? So in a patients with diabetic, with a multivessel disease patients, sometimes you might not find a reciprocal changes. The reason being is that sometimes these patients have lots of collateral supplies. So that reciprocal change disappears. So we have seen a lot of patients coming with only ST elevation with no reciprocal changes. And sometimes you think about what's happening. And then when you go and do an angiogram, that's when you see these are triple vessel disease. And straightforward nowadays, we know that once there are no reciprocal changes, but again, a patient who is young, 30 years old, with ST elevations throughout, with no reciprocal changes, there are also differential diagnosis to it. Not all ST elevations are formulated STEMI.
Yes.
But because STEMI is a life-threatening, it can cause long-term disability, morbidity, and mortality. You always have to rule it out.
Okay.
But like pericarditis,
Yeah.
in pericarditis, a young patients come with he had an influenza virus, and then after 2 weeks comes severe chest pain. You see a widespread ST elevation. UDA troponin might be elevated in these patients because there's always a myocardial damage during pericarditis. There's inflammation of the pericardium cell. So you get a release of enzymes as well during that time. And sometimes it confuses someone that should I rush this patient to thrombolyze? Should I rush this patient? So there are isoelectric P waves, there are criteria for pericarditis. So you need to see the age of the patient, you need to see the risk factor of the patient, but ECG will give you a lot of clues in a patient.
I'm going to talk about that in brief, so maybe you can also show us at that point. Now, this is just a pictorial of showing the same leads and how they look at the heart. Okay, so remember this, and this is what everyone will ask you when it comes to a MI. This is one example that I'm going to give. As you can see here, look at lead V2 and V3. There is an anterior wall STEMI, right? Okay. Now, you want to find, this is anterior with a lateral extension, I believe, because there is V2, V3, V4, V5, and also V6. But where is the reciprocal change? It's in the inferior leads. So that mnemonic of mine really works, okay? And that's how you diagnose a STEMI. So one thing I wanted to tell people is the right-sided, right ventricle MI. And many people are saying that it resolves within 10 hours sometimes. So you won't see the ECG changes. Is it true?
So this is a very right ventricular myocardial infarcts are very notorious in terms of they've got high mortality because RV dysfunction, because they are purely RV dysfunction, and the supply to this is basically inferior supply to this lead. So sometimes you don't see typical, but you see like a posterior kind of an MI which is supplying. So you see a ST depression in V4, then that's where you come to do your posterior leads. You want to see because that's basically where it is supplying basically. So V4R, those kind of leads where we ask them. So once you see an ST depression in V4 or V5,
Yeah.
either there's a trick where you do an upside down ECG or reverse your leads, go to the posterior and look for an ST elevation.
Okay.
And these are sometimes why they resolve because they are posterior, and with time the muscle gets injured, and then the isoelectric can come back again.
Okay.
And sometimes those patients don't even have a reciprocal changes.
Yeah.
It's purely a posterior MI, so they don't pick a reciprocal changes in most of the patients.
Okay.
But these patients, once you have an RV dysfunction, the mortality becomes very significant in these patients.
Okay. So what I remember, because I'm a simple guy, I like remembering a simple thing. It is when if you have, let's say you have inferior MI, right? And if the ST segment elevation is more in lead 3 compared to lead 2, you start thinking about right-sided MI, right? And another thing you can do is that you can take, whenever you have that, like you have this criteria whereby lead 3 is ST segment elevation, as you can see, is more than lead 2, you do a right-sided ECG, and like Dr. Khuzeima said, you might see some sort of ST segment elevation V2, which is more.
So this is a very
than in
interesting
V1.
ECG model.
Yes.
So if you see now this ECG,
Yes.
now we have two supplies which makes the dominance in the coronary artery. There's a right coronary artery which 70% of the people are dominant.
Yeah.
Then there are 20% of the people worldwide who are dominant from the left circumflex artery, which supplies the PDA. So when we say dominance, it means that the artery supplies the PDA and PLV branch,
Yeah.
which are supplying the sinus node of the heart. Right now, if you see this ECG of yours, you see an ST elevation in lead 3 and lead 2 and
Yeah.
lead AVL.
Yeah.
But if there is a reciprocal change in lead 1, AVL, V5 and V6.
Yes.
So this is a mirror image of a RCA territory.
Okay.
It's depicting on lateral wall.
Yeah.
So lateral wall is giving the inferior like a mirror image. But suppose he was a dominant left circumflex, then you would have seen ST elevation in 1, 2, AVL, V5, V6.
Okay.
Right? So sometimes you get it. Sometimes you have a typical kind of thing, but they are dominant left.
Yeah.
And we go in the mind with this is RCA, and RCA is normal, but because they are the dominant left circuit for us, and the PD and PLV is supplied by the left circumflex, you can get this kind of an ECG. So not always lead 3 higher means that it's RCA, but majority of the cases.
Okay,
is that.
I see. So one thing that we can do, and we can change the leads from V3 to V6 to the right side, or an isolated V4, you can change it to the right side and label it as V4 as I've done here. And you can see an ST segment elevation, and this proves that this is a right-sided MI. And when you have a right-sided MI, you cannot give nitro because it's preload dependent, right? And you need to give a bit of fluids to sustain that preload of those patients, right?
And this is a very good point. What Dr. Moiz is saying is that when patients come with PE, they're always hypotensive.
Yeah.
Just because of the preload.
Yes.
Similar to posterior wall MI, they will either come because they supply the PD and PLV, they will come with bradycardia.
Yeah.
That's one of the signs. They come with complete heart block or intermittent heart block. They come with hypotension. So these are the signs when they come from. So in this patient, whenever you are thrombolizing, you need to make sure, because streptokinase, when you give them, which was available before, it causes hypotension.
Yes.
And that's why we mix it with normal saline when we are infusing
Yeah.
it. Tenecteplase have not shown hypotensive effect when you give them as bolus. So streptokinase usually had the hypotensive effect. In
So
this case.
EM Cure is supplying tenecteplase, I think. Yeah. So posterior wall MI. Here I want to stress a bit because I asked 20 people who I know, who are my juniors, and each of them told me this is an NSTEMI. You understand? So one of the classification that we have come about is called Omni and Nomni. Omni is occlusive myocardial infarction and Nomni is non-occlusive myocardial infarction. Omni is one of the things where comes that Omni has STEMI and STEMI equivalents. And this is one of the STEMI equivalents as well. So how does it present is that a person will have the ST depressions in V1 and V2, but with a tall R wave and upright T wave. Okay. Now, in this image, if you can see, all right, V1, V2, V3, and then ST depression, right? You see a tall R wave and somehow a tall T wave. Now, if you are a bit lazy like me, you will do, okay, this is how you do a posterior ECG. You take your V4, V5, and 6, and you placed it at a V7, 8, and 9 behind the scapula, like Dr. Khuzeima was talking about. But if you are lazy, like me, like I said, you will turn the ECG upside down, and now you will see ST segment elevation. The R wave that you will see now becomes a Q wave, and this is also one way of sending your cardiologist the ECG, and it becomes a confirmatory thing. So this is very important, and we should take into account that this is a STEMI and not an NSTEMI, and we should rush to a cath lab, right? One of the other equivalents is the Venter's T waves. Now, this is marked upsloping of ST depression first in V1 to V6, and then there is a symmetrical peak T wave in the same leads. No ST elevation in the leads, and with or without T wave changes, okay? And it's associated with a proximal LED. This is how it looks like. So you can see there is an ST depression, and then there is upsloping of the T wave. This is not like a hyperacute T wave. Hyperacute T waves are very pointy. But one of my ECG guru, Dr. Amal Matu, he talks about saying that if you can fit the QRS in the T wave, think about it as a hyperacute T wave. If there is no potassium, which potassium is normal, then think of it as an MI, until proven otherwise. So what do you say about this?
This is correct, but if you see there, what we see is when we have hyperkalemia, we have a tented T wave.
Yeah.
With a sharp point. But if you see the isoelectric line, they are almost equal.
Equal.
If you see here, the isoelectric line are not equal. They're upside down. They're sloping.
True.
And in a patient with high risk factors,
Yeah.
always take it as STEMI.
Yeah.
Always
Okay.
take it as STEMI.
Okay. All right. So another thing I wanted to talk about is Scarbosa criteria, and you talk about it in when the person has a left bundle branch block or a pacer. Yeah. And now many of our patients also have a pacer. So the criteria is quite simple. There is A, B, and C. Okay. So the first one is called concordant. Concordant means that the QRS is positive, and then there is ST segment elevation in any of the leads, right? Then there is another form of concordant whereby QRS is negative, and then there is ST depression, which is in V1, V2, or V3. And the last one is discordant, meaning there is a negative QRS and then the ST segment elevation. Now, in this one, many people think that it is tricky, that you have to measure the ST segment elevation. If it's more than 5 millimeters, then this is positive. So the criteria is divided into 3, and each one has a point. If you have more than 3 points, you should start suspecting a STEMI. So there is a modified Smith criteria as well, whereby you don't take this distance and you take the ratio, meaning you take the ST segment elevation, divide by either the S wave or the R wave, and times 100, you get more than 25%. This criteria can be positive. So is there an easy way to understand this?
So the thing is that with left bundle branch block, you see, there was a study done in US. It's a whole study done in US. What they did patients coming with chest pain, and those were left bundle branch block, whether it was new or old. Only 11% had true STEMI.
Okay.
Only 11% had true STEMI. So if you see that one thing is that whenever someone presents with chest pain and left bundle branch block, if you don't have a baseline ECG, take it as STEMI.
Okay.
Right? Other than that, if the patient has an old ECG, you can bring the ECG and you can compare whether it's all left bundle branch block. But these criteria are just to guide you to say that, okay, fine, are you dealing with STEMI or are you not dealing with a STEMI patient? Because the thing is that, again, what's the criteria is we need to save the muscle. That's the end of the story.
Definitely. Yeah. I just wanted to confirm everyone is okay? Everyone is hearing us properly? Okay. So STEMI treatment now. This is just a discussion part, and I want you...
So few points probably.
Okay.
So can you go back to the slides where we have wars? You can depict wars. Whether it's a lateral, which wall, and the infected artery.
This
Okay,
yeah.
this
Yeah.
one.
So always while I was in a general practitioner, so there's always one forgotten lead, and we
Yeah,
probably
yeah,
forgot it
and
to
we
say,
forgot it.
and then the lead is AVR.
AVR,
So
yes, yes.
may I get views? Probably even other people want to
Okay,
get views
alright.
from
So
expertise on
I think
AVR.
I don't know if American Heart Association accepts that, but European Cardiac Society says that if you have ST segment elevation in AVR, okay, which is more than V1, and if there are more than 6 to 8 leads which have ST depression, then that's ST segment AVR elevation. And normally it means subendocardial cardial ischemia, which could be a left main blockage, but can be also other things. Like, for example, if you have severe sepsis, if you have severe anemia, then it can still produce because of the type 2 myocardial ischemia. So, I mean, what do you say
so
about
I
that?
think yes. I concur with Dr. Michael, but AVR usually depicts the left main.
Yeah.
Whenever you have an AVR ST elevation, always think of left main disease.
Yeah.
That's straightforward. But the other thing which he reminded me is that if you see to that ECG,
Yeah.
there's something. It's AVL also is very important.
Yeah.
The reason
Okay.
I'm telling you AVL is very important because I've seen isolated AVL ST elevation, and which patients come with severe chest pain, and the ECG is completely normal, no reciprocal, but only AVL. And this is basically when a patient has got a dominant diagonal artery,
Dominant diagonal artery.
D1,
Okay.
which is more supplying to the majority part of the heart compared to LAD.
Okay.
And if that's blocked, it's more painful even than LAD because it supplies a lot of intramuscles where the diagonal receptors. So AVL elevation, I've seen patients come with
Isolated AVL.
Someone
Okay.
sent me an ECG and you're like, looks okay, normal, and says troponin is high, and then you go back and look at it and you say, oh no, you are missing something. You go in,
Okay.
totally occlude, 100% diagonal. So AVL, AVR, these isolated leads we call it in ECG, where they can be individualized, elevated, without any reciprocal changes, but patient typical present with typical chest pain, which is angina equivalent, and STEMI and respirating.
So, because we are talking about AVL, what about that T-wave inversion in AVL? Isn't it an early sign of inferior volemi? That when you have T-wave inversion in AVL and chest pain, you should start thinking about repeating
T-wave
ECG.
inversion in AVL will not be isolated. So you'll be in lead 1, you'll be in AV5 and V6 because it's all going together. But I'm talking about the elevation.
Yeah.
The elevation.
Okay. All right. Thank you.
So that was one aspect. So the other aspect is on assessing for inferior for the reciprocal changes in other leads.
Yes.
So what if we have a patient who has chest pain of recently, and this particular patient, we know that most of our patient doesn't go to the hospital immediately.
Yeah.
And most of them have infected arteries prior, and then they have chronic occlusions.
Yes.
And then at this particular point in time, they come to the hospital, they have an acute chest pain.
Yeah.
So do we expect the same changes on ECG and the reciprocal changes, or should we expect something else? Or
So like when we talk about acute coronary syndrome, we say it's a syndrome. It takes of unstable angina, it takes of NSTEMI, it takes of STEMI. Whenever it's a STEMI, there is no question, this is an emergency. Whenever you have doubts between unstable angina and STEMI, that's where the cardiac enzymes come in. So a patient comes with not, the changes are very vague changes on ECG, because someone who have an LVH can have an LV strain pattern, where you also have an ST depression or T-wave inversions as well. So that's why the biomarkers are very important in such cases, because these are now classified as SCS with unstable angina or NSTEMI, right? And the guidelines now are evolving currently, and the guidelines now takes everything, even NSTEMI now. In the past, NSTEMI could wait. Now they say treat NSTEMI as STEMI because it can evolve into STEMI anytime. So cardiac enzymes, cardiac markers are very important during that time when you are unsure. Once you have a CKMB, once you have troponin I, which is high sensitivity troponin, elevated in a patient with all the risk factors, treat it as soon as possible, take it as STEMI.
So thank you very much, Dr. Khuzeima. So can we proceed?
Okay, let's proceed. STEMI treatment now. This one, I will let Dr. Khuzeima talk about it because he is a pioneer. Like, you know, those people who think globally and act locally is one of them. And I believe also Prof. Janabi is one of them. That he came up with a small WhatsApp group. I'm not trying to like, but he came up with a small WhatsApp group. There were people who were telling me, they will not take patients, yani. But I saw every time a patient was discussed, and that patient ended up in JKCI, and a PCI was done. So I'm really impressed by this small change, and I think we can learn a lot from it. So this, I think, it's something you should take over.
Again, the STEMI is, again, like we said, that what we are talking about is time to muscle save. We want to save that muscle, and the time we have is only 90 minutes. And that's why in the past, they were talking about whenever chest pain starts, that's when the time starts. Then the guideline evolved. They said from first medical contact. When you say first medical contact, it means a medical personnel does an ECG and detects a STEMI. That's where your time starts, tick, 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 tick. So from there, you have two pathways. You go for thrombolysis or you go for a PCI center. PCI centers are rare in our country. We at the moment all are located in Dar es Salaam, and one in Dodoma. No more than. So we more depend on thrombolysis, and this is what we can. Like you're saying, the WhatsApp group, it was started small. Now we have more than 1,000 doctors all over Tanzania, and you can see how people are starting to learn, how people are referring patients, how people are saving lives. Now, when we come to our setup, and it's not only our setup, in Europe, they were saving the same problem 20 years ago. That's where Stent Save a Life came in.
Okay.
That project started with thrombolysis. That every county in UK, every hospital should have thrombolysis. Patient comes with chest pain, ECG should be done within 5 minutes of patient arriving, or in the ambulance when an emergency ambulance is going to pick up the patient. If they see an ST elevation, and if the hospital is PCI capable center is more than 90 minutes away, they thrombolyze them in the ambulance.
Oh wow.
And then they take them to the PCI capable center and they do a facilitated PCI.
Okay.
Right? In our country, we always do a facilitated PCI because to reach 90 minutes is only Dar es Salaam.
Yeah.
Someone who is in Arusha, someone who is in Mwanza, someone who is in Sumbawanga, we need to reach out to all the emergency departments, which the government currently has put a lot of emphasis on emergency department, to make them have at least 2 to 3 vials of emergency thrombolysis and active ECG. A patient comes with risk profile, get an ECG done, send it on the group if you are in the group, send it to anyone whom you know who is a doctor who can read that ECG if you are not sure, and thrombolyze your patient before transferring the patient.
So prior to thrombolysis, what about those stat medications?
Yeah, so that's what we are going to. So that's the thing. Now, in 1987, a paper was written comparing aspirin to streptokinase. How much aspirin is life-saving in STEMI? And that paper proved that yes, those patients who were giving aspirin alone, those who were giving placebo versus those who were giving aspirin and placebo was aspirin streptokinase. Even giving an aspirin loading dose in that time, in 1987, I'm talking you about, showed there was a benefit of saving this muscle.
Okay.
Right? Now we have evolved from that. So first thing is that we load these patients. Aspirin 300 milligram.
Okay.
Clopidogrel 600 milligram. The reason you give them, yes, and atorvastatin. So the antiplatelets which you give in the beginning with a high dose is to facilitate the platelet aggregation which has taken place, to reduce the platelet aggregation, because whenever thrombus rupture, the platelet clumps, that's where the clot becomes. And then we go atorvastatin is to stabilize the unstable plaque. So atorvastatin or rosuvastatin, antiplatelet like aspirin, clopidogrel, prasugrel, ticagrelor, whatever you are giving them, whenever you give this combo, you are trying to save whatever muscle is getting injured in the beginning. Then it comes the time of thrombolysis. Immediate thrombolysis, which we have streptokinase, we got tenecteplase. We still are not getting alteplase in the country. But
alteplase
is very difficult. But what we have available, they can do magic and wonders. And that's why the emphasis now is to get board the ministry that every city or every hospital emergency department should have this thrombolysis. Okay. I know they are costly, but we need to work on the cost. That's I'm always advocating for the cost, but I'm sure that with time we'll have it. Yeah. So loading doses and thrombolysis. That's the catch for us. PCI is the next step for us.
All right. So to everyone who is in the emergency department, Patient comes in, right? At the time of get-go, I need my nurses also to recognize a STEMI when you see one. So the nurse recognizes it, tells the doctor, hey, this is a STEMI, okay? They load the patient aspirin, that first aid kit that you said that
Yes,
every
the
hospital,
toolbox.
the toolbox that everyone should have. 300 milligrams of aspirin, 600 milligrams of clopidogrel, and 80 milligrams of atorvastatin, which I also have it at my dad's place because I think yeah, we have a strong family history of MI, so even they have it. So after that, you consult a cardiologist. They confirm that yes, this patient has a STEMI. If it's more than 120 minutes, if you're going to take more than 90 minutes to reach a PCI or 120 minutes.
Yes, 120 minutes.
120 minutes, if you're going to take more than 120 to reach a PCI center, then thrombolize the patient and then allow them to do facilitated PCI. So there is no harm in giving thrombolytics and going for PCI. So I'm going to talk about thrombolytics and absolute contraindications because this is important.
Yes.
Prior intracranial hemorrhage is a no for thrombolytics, right? Therefore, PCI will benefit the patient more. Ischemic stroke less than 3 months. Can you give? You can give.
So I know it's an absolute contraindication, but the thing is that because you are saying that nowadays what they say, the neurologists say that after 14 days you can give them heparin or aspirin, everything, right? The only thing what you're worried about that you don't want an hemorrhagic transformation.
Yeah.
Yeah, that's why they are saying that except CVA within 4.5 hours. So CVA, you can give thrombolysis within 4.3 hours now.
Okay.
So to protect, like regarding myocardial infarction, the stroke
You're
society
protecting
says
the brain.
protecting the brain,
Yeah.
so you do give thrombolysis.
So
Right.
I will tell you a story. I was in the middle of a neurologist and cardiologist, and you don't want to be. So this guy presented with a feature of stroke, NIH score was around 9, 10. So he tells me thrombolize. And then I speak to a cardiologist, and he's like, they're all discussing, both of them. So I went with thrombolysis because at that point I was like, the brain is important, right? And the heart can be saved with PCI. But those kind of cases, I have seen many of them, they get complicated very fast, and this patient was intubated and had a poor outcome. So what would you advise me on the next time I have such a patient?
Recently, I think we had a patient. We have published this case in recently in Egyptian Heart Journal. A patient with non-Hodgkin lymphoma came to EMD with ischemic stroke and a myocardial infarction.
Yeah, that's what I'm talking about.
Both together. Now, in an ischemic stroke, which was already more than 10 hours, but they did an ECG which showed ST elevations.
Yeah.
So they called us. We took her to cath lab.
Yeah.
Now, whenever we're doing a PCI to these patients, we need to give heparin in the first phase, because whenever you learn a stent, you need to give heparin before your antiplatelet starts working.
Yeah.
So that was a dilemma. She has a stroke, which is more than 3 hours now. Ischemic can turn into hemorrhagic transformation when you give heparin high dose.
Yeah.
She was an 80 kilograms, so I need to give 8,000 IU of heparin during leaving a stent.
Yeah.
But risk versus benefit.
Yeah.
So we did, and we were lucky that the patient didn't have hemorrhagic transformation. We could save the heart, preserve the ejection fraction, and patient was discharged from hospital after 3 days.
Okay.
So we have published that case recently in the journal, Egyptian
So
journal.
basically, ischemic stroke, you did thrombolize, not
No, we didn't thrombolyze, but
thrombolyze.
we took her to the cath lab to do PCI.
PCI. Okay.
And then heparin was given, but not thrombolysis.
Okay.
That's why it's an absolute contraindication.
All right. Okay. So another absolute contraindication is non-malignant intracranial neoplasm or AV malformation. Suspected aortic dissection is a no. Significant head injury or facial trauma in the past 3 months. Now that also somehow I guess it's a question mark. Severe uncontrolled hypertension, which is unresponsive to therapy. Because I believe hypertension, if it's not controlled, it can cause active bleeding, right? And then we have intracranial or interspinal surgeries within 2 months. These are major surgeries, so they might have a contraindication. Active bleeding or bleeding disorder, that's there, but excluding menses. There was a junior who asked me why menses are excluded.
It's a national process.
It's a national process.
It's a national process.
Okay.
That's one thing. And
Yeah.
their patients post MI, we give them antiplatelets like
Yeah.
aspirin and clopidogrel.
Yeah.
They still get the menses,
Yes.
but they are not affected as much as like they
So-
maybe instead of 3 days they go to 5 days, but still
Okay.
We have not seen any woman coming and saying, because I'm taking clopidogrel aspirin,
Yeah.
my menses have been 10 days, 13 days, 14 days. No, we don't.
So I would advise everyone who's watching to
Yes.
read more about the relative contraindications. Okay. These are some of the complications which happen after 1 week of STEMI. I'm not going to go dwell in it, but look at it. It's more of rupture. Yeah.
So this is one of the most important thing I would like to note to all the EMD specialists who are being
Okay.
this patient.
Okay.
Put your stethoscope
And
at the apex. Sometimes we just see the ECG and it's STEMI, go to the cath lab. No,
You're
because the highest mortality when you have a myocardial infarction, anterior wall, and you
Yes.
have a VSD,
Yes.
and you go in and do a PCI in this patient without putting up your stethoscope or doing an echo to see there is a shunt, the mortality is almost 100%.
100%. Okay. All right.
Even with these patients, surgical mortality is almost 95%.
Okay.
And so if you have an acute myocardial infarction, two things: put your stethoscope. If you hear no murmur, you know you are safe, that there is no shunt.
Okay.
But once you hear a murmur, get an echo, whether that is a ischemic MR
Yeah.
or it's a VSD. You must rule it out.
So right now, EM physicians are changing because of the bedside ultrasound,
ultrasound, yes.
and we can do echo, and
There you go, yes.
even the color Doppler
Yes.
is something that you can do to see if the VSD is there, instead of hearing, which I'm not good at. So I will just do an echo whenever I want to.
Speaking of
Okay.
holosystolic mama.
Holosystolic.
So one of the
Systolic
one of
mama.
the ECG findings of ventricular aneurysm, which is the persistent ST elevation, which is there, and management usually somehow involves surgery. So you need a cardiothoracic surgeon.
No, so
or
ventricular
vascular.
aneurysm is
Ah.
basically the apex is dilated
Yeah.
due to anterior wall infarct. And
Yes.
I think we have a case already in my CCU.
Okay.
That she has undergone only a PCI,
Uh-huh.
but there is still a consistent ST elevation. So my fellow asked, what's happening?
Yeah.
So I took an echo and I showed. Basal wall, mid walls are working fine.
Mhm.
Then there is an anterior aneurysm.
Okay.
So that's why they're persistent.
So
ST
echo would be
elevation.
nice, or transesophageal echo.
Echo is fine.
Echo is fine.
Aneurysm is fine.
Okay.
And that's the area where she has also a thrombus.
Yeah.
This area.
So those of you who don't know, transesophageal echo is basically putting a probe via the esophagus and looking at the heart from inside. So, STEMI complications. One of the things I wanted to mention is if you have inferior wall MI, bradycardias are common. And usually it's Morbid's type 1 and doesn't go exceed more. It's usually good prognosis. It tends to be narrow, complex, and sometimes just supporting it or pacing if needed, right? That's what you go about.
We have seen even a complete heart block in these
Yeah.
patients. They do come.
Yeah.
We just lost a patient day before yesterday.
Yeah.
She went to a polyclinic
Uh-huh.
and massive inferior wall MI with complete heart block.
Uh-huh.
She was referred to JKCI, but she couldn't even make it from 3 kilometers away. When they brought her in, she was already dead on arrival. So
Ah.
these are quite right ventricular inferior STEMI are the most notorious ones, and their mortality is very high in these patients. So recognition, like what Doctor, my thing is that if you recognize the pattern, if you're unsure, call us, send us the ECG. Look, our numbers are available. Look for any senior doctors who could just give you an insight.
Yeah.
Don't just sit with the ECG.
And honestly, this is my personal experience that I have always called Khuzeima, whether there is a MOU or there is no MOU. I have called Khuzeima, and he has always responded. So I am grateful for you, because it is risky on your part, but you are very much helpful.
We look, like you said, it's very
Yeah.
close to your heart.
Yeah.
We all have families at home.
Yes.
This can happen to anyone,
Yes.
any time of the day.
True.
And first thing, they look for doctors around. So
Yeah.
you might be staying in a community where everyone come and look to you, and it's like something has happened,
Yeah.
and they ask answers from you. So you can keep, like Moiz said, you keep aspirin at your bag. I roam around with 300 milligram of aspirin in my bag.
Wow.
I have it in my bag.
Dedication.
Whenever 300 milligram of aspirin.
Do you have 300 milligrams of aspirin?
No, it was.
Okay, so one of the things that I learned from one of my mentors is she said, if you have inferior wall MI, bradycardia is common, but if you have inferior wall MI and tachycardia, the prognosis is poor. Is that correct?
Perfusion.
Perfusion, right?
Perfusion issues, right? So when you have tachycardia and you have inferior MI, you cause more hypoperfusion to that area. So you get
Okay.
more damage.
Yeah.
You see, as it is hypoperfused, and now you're tachycardic, so the reserve is not getting out enough, because when you're tachycardic, the amount of out, the pumping out of the blood is less.
Yeah.
You're already hypoxia, the muscle is hypoxic because
Yeah.
of the MI, and then you're causing more hypoxia because you're tachycardic.
Yeah.
So that's why even post MI beta blockers in the past were a must. Only recently they were saying that now if the heart rate is below, it's around 70-75, don't give beta blockers.
Okay.
In the recent guidelines. Now
Yeah.
beta blockers, they say that no role, no benefit. But
Okay.
till 2024, beta blockers after myocardial infarction rate should be around 70, so that you get more oxygenation to that.
Okay. So if you are less than 70, you shouldn't give beta
Yeah,
blockers.
you shouldn't give beta blockers. That's one. Second thing is that always think of reperfusion injury.
Yeah.
Whenever you have an MI, the myocardium has sudden shutdown of supply. So it goes into stunning or hibernation. So sometimes when you reperfuse them, the patient get more chest pain than what they had, because there's a reperfusion injury. And the free radicals, which they are there,
Yeah.
they call it the free IR radical, the inflammatory markers and all those, it causes more chest pain.
Yeah.
And sometimes the ST persists, and then it takes about 2 to 3 weeks to come back to baseline. So don't worry about those changes, ST elevation. As far as patient is saying now, after 24 hours of your reperfusion, there is no chest pain, forget about the ST changes. Just
Okay.
follow that patient up, and you will see slowly the R waves coming up. The revascularization has improved the circulation, but it will take time.
Okay. All right.
So sorry, Dr. Khuzeima. So
Yes.
there's something that we have said, probably it should be noted clearly, and probably you can keep emphasis on this. So beta blocker, and then we have to watch for the heart rate has to be below 70. So probably there are patients, we will discharge them at JKCI probably with beta blockers, and then the beta blockers is going to be discontinued in the peripheral. So
Not
this
only
one has
beta
to-
blockers, we have seen patients with putting a stent, they are discontinued aspirin and clopidogrel, right? So you see, the thing is that our system, the way it is, our patients don't come up with discharge summary. And when the doctors ask, what did they do at JKCI? Or what did they do at this? They say that, niliwekewa kifaa. This is what they say, right? Now, when they say that kifaa, they don't know what it is. And that's why I always tell my patient that whenever you go to the periphery, tell them kwamba hizi dawa aspirin, clopidogrel and statin, daktari amesema hata nikifunga lazima nimeze kabla ya nianze kufunga, because these are the most important medications. So always counsel your patient about these medications.
So anterior septal MI, bradycardia is a bad sign. So if you probably present with tachycardia, but if you have bradycardia and you have anterior septal wall MI, that's even a poor prognostic marker. And these guys can also present with wide complex blocks, and majority of them progress to myocardial and septal rupture. So this is Dressler syndrome, whereby a patient comes in with pericarditis, and it's usually autoimmune related, and it's not that scary, right? You can give NSAID, colchicine, and corticosteroids, and it can
So
help.
Dressler syndrome is basically, and nowadays that's why colchicine has come into play.
Yeah.
Post myocardial infarction,
Yeah.
colchicine reduces inflammation and prevents from Dressler
Yeah.
syndrome. So Dressler syndrome is one of the post myocardial complications
Yeah.
of myopericarditis, and sometimes that's why nowadays all patients we give them colchicine to these patients. So colchicine is one of the now approved medication in chronic coronary syndrome and post acute myocardial infarction to reduce myocardial inflammation, basically.
Okay. So this is, I'm going to go very fast here because I don't want to take much of time, but it's NSTEMI. Now this is non-occlusive myocardial infarction, okay? The pathophysiology is the same. You have an atherosclerotic plaque, and then that ruptures and you're exposing your endothelium, and then now platelets and fibrin attach there. Now there are two things which can happen. Either fibrin will excessively attach and cause occlusion, which is STEMI, or there will be fibroblasts which will come and create a stenotic lesion which will now become non-occlusive, like some part of the blood flow is there. And the last spectrum is unstable angina. So the spectrum is that unstable angina, troponins are negative and there are no cell death. But in NSTEMI and STEMI, troponin is usually positive and there is cell death. Now for STEMI, the diagnosis is mostly ECG related and not troponin. So we shouldn't wait for troponin, right? For a STEMI. If there is a STEMI on the ECG, then we shouldn't wait for the troponin, because even the high sensitivity troponin can be raised because of other reasons, right? And even those troponin rises in 3 hours. So if a person comes in 1 hour and has an ECG of STEMI, we shouldn't wait for troponin. Now, these are the causes and risk factors. We all know that plaque rupture is the most common, and males are more affected. Sorry, males. Hypertensive, diabetic, hyperlipidemic patients, Indians mostly. We are all hypertensive, diabetic, and now even Africans are getting there, by the way, because of KFC or what. So
I think,
yeah.
Moiz, I think Professor Kaushik, if I'm not mistaken,
Yes.
they've done a study, and we saw that the highest diabetes patient in our community were those with high standard of living.
Okay, yeah.
Right?
So anyone.
Yes, that's first. Second thing was Asian communities.
Okay.
Very prominent Asian communities. Asian communities cuts out through Asian communities. Very high risk with diabetes, and these are very high risk of getting myocardial.
Yes, the silent ones.
Silent. Nowadays, those born after 1980s, I think we are all at one par.
Yeah.
Compared to those who were before that era, because our food, our lifestyle,
It's the same.
our lifestyle is so bad at the moment that the risk cuts across. The obesity is very high,
Yeah.
exercise is very less, sitting is very high, stress is a lot.
Yeah.
See, you leave work, to reach home it takes you 3 hours in the car, you're just sitting.
Yeah.
In between, you open up your window in the car and you buy those street vendors, whatever you get, crisps on the road, karanga, the peanuts on the road. You go home, you reach home at around 9, 9:30, 10,
Yeah.
you eat food. You go to sleep within an hour, even without digestion taking place. So there are lots of things we need to change, because we say prevention is better than cure.
Yeah.
To prevent this, we need to advocate to our patients, to our communities, to our colleagues, regular exercise, to prevent these detrimental diseases which has got lifelong morbidity, mortality, and financial burden, not only on you, but at community at large and as a country at large. Right? So advocating a healthy lifestyle is very important in this era at the moment.
Definitely. So I was just going to talk about chest pain a bit, that this chest pain is like common, right? It's a squeezing chest pain, retrosternal, radiating to the left or right, or even the jaw or the neck. And I had a patient, actually, a nun. She came with jaw pain. She went to the dentist. Her tooth was removed. ECG was done. Anterior wall STEMI. Tooth was removed, and so you can see how chest pain is. Chest pain equals to ECG, by the way. That is the emergency way, and everywhere it should be like that. Atypical, if it's a woman, if it's an elderly, it's a diabetic, think about atypical signs like vomiting, scapular pain, fatigue, and epigastric pain. Epigastric pain also means ECG for you, or chest pain. So we should be doing that, because many, like my mom, there was a time my mom told me that, hey, I took a lady home, she has gas, and I gave her pantoprazole. Next day, we heard lady passed away.
Yeah.
So this has happened a lot. And
And it's still happening. It's still happening,
Yeah.
because every person thinks, you see, it's very scary to say that I'm having an myocardial infarction.
Yes.
And all I tell my patient is that any time of the night or any time of the day, if you have a chest pain, just get an ECG done.
Yes.
And Dr. Moiz, like he mentioned in the beginning, not only single ECG. Get the first ECG done. If it's a normal ECG, treat something else which is not there. Get another ECG as early as 2 or 4 hours. If there is no evolution of that ECG within the next 2 hours, then you are safe. If there is any new changes on the ECG, then you are not safe.
Yeah, definitely.
Right? So ECG, I always tell my patients, any time of the night, you get a chest pain, just go and get an ECG done to nearest center.
Definitely.
Once ECG is clear, you can go back to sleep.
So MI changes on ECG. ST elevation not always means MI, right? So you can have causes like pericarditis, benign early repolarization. So let's talk about that a bit, and then so our ST segment elevation is non-concave, which is convex. So I like this way: non-concave, concave. So if you have a concave ST segment elevation, if the patient is high risk, you still think of ST segment elevation, right? Or should you think of pericarditis? Because I have read that concave means pericarditis and non-concave is ST segment elevation.
So again, the thing is in pericarditis is the whole inflammation of the pericardium.
Yeah.
So all the electric current passing throughout the pericardium of muscle,
Yeah.
you get ST elevation throughout.
Like this one,
This is
right?
what you are saying.
Yeah.
And if you see the hallmark of pericarditis, marked ST elevation all the way
Yeah.
with P waves below the isoelectric line.
Yeah.
And this is very important. The P waves are below the isoelectric line. So if
Yeah.
you see here, Moiz, you
ST
can show
segment.
the P waves are below the isoelectric
Like
line.
this sagging of
So
PR.
if you see your isoelectric line is this boxes of 10 millivolt,
Yeah,
that
yeah.
makes your isoelectric.
Yeah.
Your P waves are below the isoelectric
Yeah,
line. This is one of the
yeah.
very prominent features. Then you might have a PR interval prolongation
Uh-huh.
in a pericarditis.
And what about AVR having PR of AVR elevated? Is that a sign in pericarditis?
So you might not get that. You might not
Okay.
get it because P waves in AVR is basically giving you the axis of the ECG. So when
Okay.
we say when you have a sinus,
Mhm.
your P wave should be upright in lead 1,
Okay.
lead 2, and downwards in lead AVR. This
Okay.
is like a true ECG.
Okay.
So whenever you have P waves up down, you need to concomitant leads. You need to see whether you have reversed your leads or you have done anything else. So
Okay.
to see, unless it's a dextrocardia patient.
All right.
Yeah.
Yeah.
The dextrocardia, you might get the opposite because
So,
you are putting on the left side.
Our viewers should read on this
Yes.
of dextrocardia and
So
what is
whenever you
a
have lead
reverse
reversal,
leads.
is
Yeah.
two things: either
Okay.
dextrocardia or lead reversal.
Lead
So you need
reversal.
to- if lead reversal is okay, that's why I said auscultate your apex.
Yeah,
Is it
yeah.
on the right or the left?
So you said it's your dad, right, who has
Yes.
dextrocardia. So this true example. Okay. So I was just talking about troponin now. We have high sensitive troponin and we have the troponin I. Troponin I rises in 3 to 6 hours. So that's why I was saying that it shouldn't be relied on when it comes to STEMI. ECG is the first thing. Okay. High sensitive troponin can rise within 1 hour, but can normalizes in 7 to 14 days. And the time of rise is actually the delta time, right? The delta of the troponin. So 0 and then it rises to a certain point. That's when you start thinking about if there is an ST segment change or if there is NSTEMI, then you start thinking about NSTEMI because troponin now rise. So that is what I'm going to talk about is the heart score. We use the heart score. I know you guys use Grace score, Timmy score.
So this is the first score to treat
Uh-huh.
a STEMI patient.
Okay.
Heart score.
Heart score.
Heart
Okay.
score will give you a criteria that whether this patient falls into STEMI criteria, yes or no.
Okay.
TIMI scores, Gray scores are mortality scores.
Mortality
What are the
score, okay.
30-day mortality? What
Uh-huh.
are the 6 months mortality in this
Okay.
patient? So after
Alright.
myocardial infarction.
Okay.
So heart score is the first thing you need to do to say suspicious, not suspicious.
Okay.
And I think you get
So basically, the heart score is the heart itself is a mnemonic: history, ECG, age, risk factor, and troponin. Okay, so we have to do troponin in order to use the heart score, and the score is 0 to 3 if it's low risk, 4 to 6 if it's moderate, and 7 to 10 if it's high risk. So those people who are in moderate to high risk, at the end of the day, you need to have a heart pathway. The heart pathway includes serial troponins and whether you're going to observe the patient or admit the patient. Now here the point to be noted is that if you have a heart score of 4 to 10, regardless of serial troponins, you may observe the patient, or if you're not sure, like what I do, if the patient comes at night and I'm thinking I'd admit, I don't let that person. I know it's a bit like that, but every patient who has come at night, I let them go home, they die. So for me, it's maybe superstitious, but I've done that on my as a safety net. And I tell them why. And 24 hours later in the morning, if they're okay, if the serial troponins are okay, I let them go. So
Sorry, Dr. Moiz. So when
Yes.
saying serial troponin, I'm
Yes.
sure there are people who doesn't understand what
okay.
is serial troponin.
Yeah,
After
yeah.
how long should I repeat
So
the troponin?
there are several criteria. The pathway that we use, the chest pain pathway, is 0, 3, 6, okay? Hours. After 0 hours, first 0 hours, then 3 hours, then 6 hours, and you need to know the rise time. So maybe you can shed some light on that.
So like you said, the peak,
Yeah.
the first myocardial biomarkers which are released, the oxidative age after the oxidative stress is myoglobin, and CKMB.
CKMB, yeah.
These are the most common.
Yes.
So get your myoglobin if it's possible, get your CKMB. Troponin I the troponin I, the normal troponin I, can rise after 8 hours minimum.
Okay.
The high sensitive troponin now rises within 1 hour, like you said.
Yeah.
So, and then the troponin has a peak and there's a plateau and then starts falling down at 7 to 14 days.
Okay.
So, anyone who has come with a chest pain after let's say 24, 48 hours, then there's no need of CKMB or myoglobin. Get a troponin I.
Yeah.
If you see there's a rise, then you say, look, you had an event, but maybe that thrombus might have dissolved or whatever it is, but you need to go further to check it.
Okay.
Right? But
Yeah.
the thing is, first thing, myoglobin, CKMB, troponin.
Yeah.
Now, troponin T, some people they do troponin T. Now, troponin T is a non-specific marker because it can be released by
It's
multiple
non-specific.
organs.
Yeah.
And sometimes, even if you have a chronic kidney disease,
It can
then
rise.
the troponin T can rise. And even troponin I can rise in chronic disease.
Yeah.
Only the high sensitive troponin usually doesn't rise in
Yeah.
CKD. So sometimes I see patients where troponin rise, they send us to us for angiogram or maybe something.
Yeah.
It's good that you send to us so that the patient is safe, but sometimes we don't take them to cath lab. We just
Okay.
explain that this is what the criteria is, and then we do echo, we do ECG,
And
we
they
again
find
follow them up, and then we say, okay, fine, there is this a risk factor to take him, then we decide.
Okay.
So thank you. So that
Yeah.
actually answered the question that has been asked by Dr. Msele online.
Okay.
The question was regarding to serial troponin to a patient who had CKD.
Yeah.
Is it beneficial? Is it beneficial? Should we do serial creatinine in the setting where
Yeah.
they cannot do any other investigation
Yeah.
apart from that? So I think that
That answered the
sufficiently
question,
answered
hopefully.
that.
So in a CKD, we something called uremic pericarditis can give you ST elevations.
Yeah.
High chest gap with chest pain, creatines are high, your potassium is high, you see stall tented T waves, patient has chest pain, now you say, okay, it's systemic because your troponins are also now
Okay.
raised.
Yeah.
You go send the patient for dialysis, patient come with no chest pain. So uremic pericarditis is one of the things which I have confused sometimes
Sometimes
with
as a-
STEMI as well. So
Okay.
take into consideration all these things. See as a patient as a whole with
And
ECG
not just
and
one.
not one.
Okay. So cardiac stress tests, I'm not going to go into it, but if you have chest pain, if the patient has chest pain, don't send them for a stress test, right? You might aggravate and you might defibrillate this patient at the
I
end of
think
the day.
recently we had a case
Yeah.
in our group, STEMI group.
Yeah, yeah.
Yes, a
Yeah.
patient with chest pain and went for stress test,
Stress
and then
test,
there
yeah.
was an ST elevation
Yeah.
on the treadmill stress test. Patient was brought and we did the PCI. I think we shared the
Yeah,
results on the group as
definitely,
well.
yeah.
So, yeah.
So the bottom line is, if here oxygen also, if the oxygen is less than 90, then only give oxygen because of the redox trial, right?
Redox trial,
That
yes.
oxygen can cause oxidative stress
To the
and cause more
more
injury.
more harm.
Yeah, more harm than nitroglycerin is relieving pain but has no proven mortality benefits. But you can give because the patient is discomfort. So
But
let's
only
say,
keep your eyes on your blood
Yeah,
pressures.
you
Don't
are,
just give
definitely,
nitroglycerin.
yes.
Blood pressure should be.
so how I give it, there are two ways of giving it, right? There is that sublingual or spray, and you take a monitor look of your blood pressure. You're on bedside. You don't leave the person. Or there in Tintinali, our book of emergency, talks about infusion of nitroglycerin, and you look at the map. You can decrease the map by 30%. If there is no relief in chest pain, then you go to something like fentanyl, or that is much more better at the end of the day. So antiplatelets, aspirin, and P2Y2. Now P2Y2, clopidogrel and aspirin,
Yes.
but there is ticagrelor, prasugrel.
Prasugrel.
When do you give that?
So, clopidogrel is the most commonly available
Yes.
drug. So, whenever we give these dual antiplatelets,
Yeah.
is to inhibit the platelet activity. So, when you are putting a stent, it's a foreign body. So, immediately the platelets will say, this is a foreign body, I need to go and clamp it.
Yeah.
And that's why you give them high dose. So, you need immediate action of antiplatelet.
Yeah.
Prasugrel, ticagrelor is a good short, is faster acting. So, that's why ticagrelor dose is 180 start and starts working within 30 minutes.
30 minutes.
Prasugrel same way is a short, but it works about 1.5 hours.
So
Clopidogrel takes about almost 2 to 3 hours.
which is recommended to be
all
given
of them?
if the
Whatever
person is going for
available,
PCI
whatever you have available.
or whatever you
Whatever you have available.
Okay.
So clopidogrel is 600, ticagrelor is 180, prasugrel is 60.
Okay.
Following up dose, ticagrelor is 90 BD, clopidogrel is only 75. Prasugrel is if the way patient is above 75-year-old, prasugrel is 5 milligram. If it's less than 75-year-old, is 10 milligram.
Okay.
Right, so their doses to prevent any bleeding,
Okay.
right, in these patients.
So
that's what it-
thrombolytics for STEMI when PCI is not available. That's just a reminder. Unfractionated or low molecular weight heparin for STEMI or
It is
NSTEMI.
not proven benefit, but yes, you
Okay.
can give because you know
Okay.
in a STEMI there is always a plaque.
Yeah.
So you can put them on a heparin dose or
Okay.
unfractionated before you transferring the patient if you don't have thrombolysis.
Okay.
We say not something is better than nothing,
Yeah. Okay.
right?
Right. So unstable angina, I'm not going to go much on it, but pain at rest during sleep, new onset, increased frequency or severity during duration. ECG may show ST segment changes or T wave inversions, and the treatment is usually dual antiplatelets, aspirin and clopidogrel, and admit the patient for some time so that you rule out an NSTEMI in this case. And this is something that shows about ST elevation and non-ST elevation, cardiac markers positive, myocardial infarction, STEMI, and STEMI. Now, this is something that you are going to talk about, so I'm just going to go through it like fast, and you will explain more. So he's going to explain about Wellens syndrome and why it's important. Variant angina, you can go and read on that. And these are my references. So
For the meantime, so we are going to have a presentation on Wellens syndrome vis-a-vis STEMI and how to recognize the EKG pattern. So this will be taken. This will be done by Dr. Khuzeima Khanbhai. So please welcome.
okay, just one
So
second.
this is just one of the cases which I presented in 2019 in Africa STEMI Live conference in Nairobi, and I thought this is one of the equivalents of STEMI, and it can be missed. So I said I'll show you this case. This is a young lady. This is a teacher by profession. 32-year-old lady came with chest pain, and the ECG. So I mean, yeah. So just go to the next slide.
All right.
Yes, next slide. So I'll just really go to this. So this was our ECG.
Okay. Can everyone see it?
Yes.
Yeah.
Yes.
Okay,
So you can see this ECG taken at admission and taken at day 7. So this patient came, and you can see the ST elevation in this patient, how they are curving in the anterior lead. You hardly see a reciprocal change in this patient.
Yeah.
That's what we are talking about. That when you have a STEMI, you have a reciprocal change.
Yeah.
But in this patient, you don't see any reciprocal change.
So you're talking about it here, right?
Yeah, so you can see how the anterior curving are.
Yeah.
And from V2, V3, and then if you go to V4, then you see some T wave inversions in V5 and V6, and slight V10 in 1.
Yeah.
But other than that, you don't see those inferior changes in the lead 2, 3, and AVF. You don't see those, right?
Yeah.
And then this patient had chest pain.
Okay.
So once we saw this was my first case of Wellens syndrome, right? And you know, at that time, the enthusiastic that what's happening in a young 32-year-old, right? With chest pain, troponin. Yeah. So if you see this, look at this troponin.
Sorry.
Go back. So this, look at this troponin T. At that time, we are doing troponin T.
Yeah.
And troponin T is normal in this patient, right? So you see ST elevations. You think this is a STEMI pattern, and now your troponins are negative. So you see, these are the unusual patterns of STEMI, we call it. And I think there's a sheet I've sent it even in the group sometimes that there are about 4 to 5 patterns which can be missed as STEMI.
Okay.
And if you see this patient come with ST elevation, typical negative troponin. What do I do? This is troponin T, which I would expect to go rise even in this kind of injury, right?
Yeah.
And you can see this. This is the angiogram. You can see I noted down where the lesion is.
Here.
Totally occluded left anterior descending artery.
Thin,
like completely thinned up. And then the next image is post PCI. And this is a 32-year-old lady.
Okay.
Right? So this is one of the unusual presentation. So this is what we call it as Wellens syndrome.
One thing I have learned is that there is this saying when it comes to Wellens. Okay. When the pain resolves, the ECG evolves. Meaning when you don't have pain, that's when
ECG shows
up.
ST elevation.
But when you have pain, the ST segment is normal.
This can also happen in something called spontaneous coronary dissection. When young patient, especially pregnant ladies with the stress of pregnancy, they present with severe chest pain. And this patient has got ST changes, elevation. But in this patient, you also have troponin raise. But when you go to cath lab, we always make sure that we don't inject the dye with force, because there are high chances this patient got spontaneous coronary artery dissection, and when you inject the dye with force, you cause more dissection throughout the artery. The treatment is not stenting, The treatment is just conservative management and it just heals spontaneously. So
Okay.
yes, we see this patient. So I wanted to show this case because this is an unusual presentation of STEMI, where you can have these ST changes and troponin are negative, and you're like, oh my god, what's happening? Should I continue repeating? No, this is what patient do present with in this. Yeah.
All right.
So this was a Wellens syndrome discussion, and yes, thank you very much.
All right.
So in a nutshell, probably it's the first time for some of the attendees to hear the word Wellens. So in a nutshell, what is Wellens syndrome?
Wellens is someone known as Wellens who recognize this pattern. So it's someone there were type A and type B Wellens syndrome. Where in type A you have got more ST elevation in V2 compared to V3. So that type A and type B Wellens syndrome, and it was someone called Wellens who identified this. So that's why it was named after him as Wellens. Wellens. Like a carbosaccharide is someone's name. It's not something.
So I was just because you were
there you go.
presenting.
Yes,
This
type B and
is
type A.
how the Wellens
Presents
will look at.
basically.
So you can see this is type B, where there is a deep wave. That was
This
type
was
B,
type
eh?
B, yes.
And then this one here is their biphasic T wave. Yeah, and this is what Wellens is. And the issue with Wellens is that it is proximal AD stenosis, right? And which we saw that on this case
This was
as well.
more of a mid LED.
Mid LED, but mostly
mostly the approximate.
and then the issue is that there is a high risk of progression to interior wall MI.
yes,
Yeah, that's it. All right. So here I should send a patient. It's a Wellens patient. I send them to
Yes.
for urgent cath, not emergent cath,
Not
but
yes,
urgent cath.
yes. They need a cath basically.
Okay.
And then
All right. So the treatment is dual anti
it's the same
therapy.
treatment.
Yeah. Okay, guys, that was from us. Yeah.
But we can share that.
So
Yeah.
while Dr. Moiz is trying to organize and play that, probably we can
Take some questions.
take
right?
some questions and try to address
Okay.
them. So one of
Let
it
me-
is there a role of morphine on ischemic pain?
So morphine, in the past they were saying Mona. Mona was a mnemonic
Yeah.
for myocardial infarction. Morphine, oxygen,
oxygen,
nitrates,
nitrates,
and
and
aspirin. Mona. Nowadays, morphine has no role in ischemic pain. In fact, we want the patient to have pain so that we know that myocardium is alive. When you release that pain, we think the myocardium is dead tissue now. And that would also delay the treatment in these patients. So we want ischemic pain in the patient who comes with chest pain. So we know that myocardium is alive and it needs reperfusion. Once you relieve that pain, patient is pain free. The first thing is the patient says, okay, I'm fine. Second thing is we don't know whether the myocardium is alive or dead. Because we got patients who come with after 24 hours, no chest pain. Myocardium is already infarcted. Reperfusion in those patients are class 3 indication, means contraindicated. You don't need to reperfuse that. You send them for cardiac MRI, you see the extent of myocardial injury. If there is a viable tissue, then you only go back to revascularization. If there is no viable tissue, don't vascularize. We only give chest pain medication after reperfusion if there is like anti-inflammatory, which causes and stuff. And I always tell my patients on the table, the pain will last because I've reperfused. The pain will last for next 24 hours and then you will be pain free after that. And that's always happens. So morphine has no more there now.
So another thing probably Dr. Moiz will chip in later on, but I will start with Dr. Khuzeima. So we have a lot of criteria in diagnosing MI in regarding to left bundle branch block, of which we had with the previous Gabos and then the modified one. What concept do we get in diagnosing MI in cases of right bundle branch block? What should we expect from that perspective? Yeah, this one has. Yeah, this is nice.
Right. So if you see this is what we have made, and I think this is a protocol we all need to follow. And this is now already online, and you can get from many WhatsApp group now. It's roaming around. I would suggest to print this out in any emergency or any hospital. Put it at your emergency center. This will guide you. So it says evaluate your chest pain, whether probability is high of ischemia or not. Do your cardiac markers. Secure your IV cannulas, large bore cannulas, because anytime patient can be hypotensive. Check your blood pressure, glucose level. Initiate your loading dose. But before initiating loading dose, there is this STEMI pattern which I've written ECG pattern. So this is one of the criteria we have put, that there is an upsloping of ST elevation. Then you go to your medication, where there is aspirin, clopidogrel, ticagrelor, prasugrel, enoxaparin, but unfractionated heparin also doses there. Then you evaluate the risk factors, and then you see if the patient is 90 away from PCI capable center or not. Then we have given you a dose of thrombolysis, how to give tenecteplase or streptokinase. Streptokinase is given 1.5 million units. You take the whole vial, dilute with 5 mils of normal saline, and put it in a 30 to 50 mils of normal saline, and run it over 30 minutes. Things to look for is reaction to streptokinase, hypotension. Those are the things. Then you have tenecteplase, which is weight based, more than 60 kilogram, 60 to 70 kilogram, more than 70 to 80 or 90 kilogram. These are the doses as per tenecteplase, how to give. And then if you go down, this is now the most important ECG, which says, like I was talking about, when you have an acute coronary occlusion, the normal hyperacute T waves, what happens in 6 to 12 hours when the Q waves start developing. So if you intervene within 6 to 12 hours, then the reperfusion injury will take place. And you can see now, go down, which is terminal T wave pattern A, then later how the T waves are coming down, then you still have them, and then it starts evolving. But if you miss the golden hour, then you start developing the Q waves, right? So this is very much important to see how evolvement of ECG happens, basically. All right.
Yeah.
So this is which is very important for this. So and then we say that transfer to PCI center or facilitated PCI to this patient. We know that SCS has a very high mortality. So to improve STEMI care in the country, I think we need to work together. And this chart is available. You can print it, you can get it, you can contact us if you don't have it, if you're not in a STEMI group, and we'll send it to you, basically.
Anything else to say?
So there was a question by Dr. Ismail.
Yes.
And he said about the role of N-acetylcysteine to prevent reperfusion injury. The exact way he asked was this way. He said, Dr. Khuzeima mentioned about reperfusion injury, which is not much considered. Would nitroglycerin assist reduce oxygen radicals? That's one question. And there was an isolated study through did get popularity on the use of N-acetylcysteine to prevent reperfusion injury. Any comments on this?
Yeah. So on the use of nitroglycerin, yes, post-MI colchicine reduces inflammation and reduces the oxidative stress, and that's why colchicine is being used. But sometimes we use also nicorandil or isosobite to reduce the free radicals on the wall stress on the wall of the epicardial wall of the vessel, where the nitric oxide is released. Yeah, so we want more free radical to prevent. N-acetylcysteine, I'm not sure. I need to go and check on that paper. So I'm not sure about the N-acetylcysteine, but I'm sure Dr. Ismail read it, so it must have benefit. But I'll need to check on the N-acetylcysteine before I can comment on this forum.
So the other question was, in a nutshell, can you talk about missed MI as far as ECGs are concerned?
Yes. So when you talk about missed STEMI, first thing is first. Is there a Q wave development? So patient in an MI, and there's already evolving Q waves, means that infarct is taking place. Now when the patient comes later than 12 hours, 24 hours, if there's a Q wave, but there's an ongoing chest pain, this shows that there's a missed STEMI with still viable myocardium. These patients can be reperfused within 72 hours. But if you have a patient who comes with you with a missed STEMI, already infarcted territory, Q waves are developed, no chest pain, this patient doesn't have any benefit for revascularization. So you don't revascularize this patient. Like I said, you send him for a cardiac MRI, see the viable myocardium. If it's there, you bring them back for reperfusion.
So on top of that, probably for understanding,
Yes.
so at what point in time will this patient cross the line from ACS to CCS?
So chronic coronary ACS is first 72 hours nowadays. Anything for after 72 hours, it's basically gone. This is a STEMI, a dead tissue, right? And in chronic coronary syndrome, it's not a dead tissue. Chronic coronary syndrome is that there is an angina, which is a stable angina, which was in the past as part of chronic coronary syndrome. Right? So chronic coronary syndrome is patient comes with stable angina, you go and do an angio or multivessel disease. These are chronic coronary syndrome, like diabetes and all those things. So there is a cutoff between chronic and acute coronary syndrome. This is like a STEMI, and now they have an ischemic cardiomyopathy because now that muscle is gone, it's a dead tissue, and you can't do anything about that tissue.
So thank you, Dr. Khuzeima. So I'm trying to check for other questions. So we have a question here: how to go with a patient with bifascicular block in the absence of baseline EKG? I think it's out of range.
Yes.
Yeah, it's out of range for today.
There
So will
was-
you discharge a patient post-MI, knowing that papillary muscle rupture and intraventricular septal rupture could occur within 3 to 5 days?
So we usually discharge patient within 24 hours of STEMI.
Yeah.
These are the complications of STEMI, which can happen, which are rare. And whenever you have a patient with STEMI, you do a pre-echo and a post-discharge echo to see if the myocardium, no ventricular rupture, no papillary rupture, everything. And you tell the patients that if you feel there's something wrong, then they could come back physically. But
So
we discharge them within 24
we're just
hours.
going to allow our sponsors, EM Cure, to show us a short video. It won't take that much of your time, and then we are going to finalize our discussion and call it a day, okay?
Thank you, Dr. Moiz and Dr. Khuzeima.
The heart pumps blood to the heart via
And I think we have
One
one
more.
more question
Wait again.
from who?
So
I think
there
there
was
a question
a,
about CABG.
yeah.
So emergency CABG, we are still in the process. But when a patient comes with STEMI and triple vessel disease, we always involve a surgeon that if they can take up for emergency. But sometimes the patients are already loaded with clopidogrel and aspirin, and it becomes a high bleeding risk. So what we do at the moment is we stent the STEMI artery related artery, the infarcted artery, which is the one which has brought the patient. Then the patient will be, after 6 months, will be sent for CABG. So it's like a facilitated CABG in this patient. So we treat the one which the patient has infarction, and then after that the patient is stabilized, and then patient is sent to the surgeons for a bypass surgery later on. So antiplatelets nowadays can go up to 1 month only, dual antiplatelets, and you can turn to single antiplatelets. Recent study showed ticagrelor now showed beneficial that after 1 month you can remove your aspirin, you can continue with ticagrelor. But minimum at least 3 months of dual antiplatelet if you want to send it for CABG. Then before CABG we stop the clopidogrel, patient can continue the aspirin, and they can go for CABG. So I think
You can close it.
Michael.
Yeah. So I think the last comment was really important. I think we will discuss in the later sessions. Will that open the door for hybrid revascularization or not? But I would like to extend my heartfelt and sincere congratulations and for our sponsor primarily, the EMQR, who have been with us and sponsored this particular event today. And also I would like to extend my heartfelt congratulations and thanks and sincere appreciations to the organization that have joined hand today. That is from the Badbury Health Professional, the Device and Arrhythmia Society, and EMSA for also being a major sponsor on this particular event today. I hope it has been a very educative session and everyone has enjoyed and has learned. So as always, so we are going to have our next session on 16th of February. So on the same dates, but next month. So as always, stay curious and stay dedicated so that we can save more life, particularly through this CME. Thank you very much.
Could you share your JKCI emergency number
Yes,
in
I
case we have a patient who needs your urgent care for
I think
MI?
there's a STEMI number.
Okay.
You can just put it on the group. I'll give
Yeah.
it.
So
Let me put it
yeah.
there and you guys can.
So it's 0689
0688
9898
98
273
273
739.
739. There you go, gratis, the number. So thank you very much once again and see you on the next time, 16th of February 2025.
Thank you, everyone.
And a round of applause for everyone. All right. Bye-bye.
It has been wonderful.
All right.